It's been more than 60 years since the Surgeon General first put warnings on cigarette packages. But tobacco use remains a menace to public health. Now, a new quality measure aims to tackle the old problem of tobacco use in new ways. I'm Andy Reynolds. Today on Quality Matters, quality's latest tool in the fight against tobacco. I spoke with two people at NCQA who know the most about the new quality measure.
My name is Jules Reich. I am a senior healthcare analyst at NCQA in population health.
I'm Grace Glennon. I'm a director of digital quality informatics here at NCQA.
Jules and Grace, you are architects of NCQA's latest tool to fight tobacco use. It is a quality measure coming out this summer for first-year use in 2026 as part of the Healthcare Effectiveness Data and Information Set, or HEDIS. The measure is named Tobacco Use Screening and Cessation Intervention. And Jules, we know the Trump administration is interested in wellness and chronic illness as part of the MAHA agenda, Make America Healthy Again. And I have to confess, when I saw the title of the measure you've made, Tobacco Use Screening and Cessation Intervention, first thing I thought was, this sounds like a MAHA measure. Is it?
NCQA has always been focused on prevention. We've had an NCQA wellness and health promotion quality program for many years. This tobacco cessation measure was developed before the change in administration under NCQA's longstanding contract with CMS. But we're encouraged this new HEDIS measure has continued to receive support from the current administration as part of MAHA. Wellness means many things to different people, and there's a lot of health topics go under the umbrella category of wellness. Tobacco cessation and tobacco use control are key parts of wellness that sometimes go overlooked, but tobacco use is a major driver of chronic disease, so we think it's important to emphasize.
Smoking rates have declined in recent decades, but the number of smokers in the U.S. still stands at about 31 million, which is roughly the population of Texas, so lots of people. We also know that tobacco use remains the leading cause of preventable disease, disability, and death in the U.S. Those facts speak for themselves, but what else is important to know about why we need this HEDIS measure for tobacco use and cessation now?
The way we see it, it's always a good time to focus on tobacco use screening and cessation intervention. Often it takes people several tries to quit tobacco. We know how important it is for people to have access to evidence-based treatment when trying to quit. It can take years, and having support from a trusted provider and being able to receive medications. The Department of Health and Human Services Healthy People 2030 goals does include a goal to increase the number of people receiving smoking cessation counseling and receiving medications to help them quit. If that's appropriate, really does help in helping more people quit tobacco use.
The name of the new measure indicates that it's a twofer: tobacco use screening and cessation intervention. Explain that, please.
There's two pieces, two rates within the same measure. A variety of HEDIS measures use the word screening. In this case, the screening for tobacco use refers to asking about tobacco. Clinicians use the two A's and R's for tobacco use, which are ask, advise, and refer. So our first rate looks at that screening. Did clinicians ask about tobacco use? And the cessation intervention rate is the follow-up of the screening. We're trying to incentivize the right cessation intervention, that right quality action going to the people who can actually use it. It's important, if we're asking health plans to perform a screening, to ask patients some kind of follow-up for people who screen positive. That's where the advise and refer come in.
Tobacco-related measures have been in HEDIS for decades. Tell me how this measure relates to what's come before.
This new measure is going to replace a measure that doesn't work as well, that was a survey measure. And the survey measure asks people to recall if their physician spoke to them about tobacco cessation or if counseling happened. And that was a problem for a lot of reasons. Most of the time when people go in for a medical appointment, it's some reason other than only to talk about tobacco. So they might not be able to recall that part of the conversation. And it also didn't give us a sense of our clinicians asking people about their tobacco use every time, every visit. So having that measure will encourage health systems, health plans to be systematic about training providers around tobacco use. And cessation intervention will also help us get better data on screening and tobacco use rates, which we can use to further population health.
Am I right in understanding the previous measure that has been replaced was part of CAPS, the Consumer Assessment of Healthcare Providers and Systems?
Yep, it was a CAPS measure.
I think of CAPS as questions about patient experience. Do you like your doctor? Is it easy to get an appointment? That sort of thing. I thought it was strange there would be a question about tobacco use part of CAPS.
You're not the only one who thought it was strange. It was in HEDIS as a CAPS measure for a long time because we didn't want to retire it without a replacement. That's how important tobacco use screening and cessation is. It's a good milestone for NCQA to replace that survey measure and keep CAPS measures more focused on patient experience and give it a chance for patients to report their perceptions about visits and leave the responsibility to focus on tobacco use screening and cessation intervention to the back end so it's not a burden on patients. It's likely more accurate to have healthcare professionals document it. Pretty much any provider you see could do tobacco use screening or have a role to play in those cessation and conversations. We know from years of studying attempts to quit that intervention from a healthcare provider on that personal level is one of the most effective forms of counseling and most effective and successful quit attempts. So it's important organizations are reinforcing clinicians have this tobacco use screening for all patients as part of their standards of work and are able to track cessation intervention referrals and screening questions.
So Jules, are you saying that I'll quit if my doctor tells me to do so, but I won't if my spouse tells me to quit?
Everybody walks past anti-smoking billboards all day, sees TV ads, and has been exposed to that for their whole lives. But there's a lot of research pointing out that personalized conversation with a provider is more effective, maybe even than a spouse.
Let's zero in on specific things that are different in this measure, starting with who or whom the measure assesses. The measure this replaces applied to people age 18 and older. Who's in the eligible population for the new measure?
This measure applies to a lot of people. It applies to ages 12 and up. There's no upper age limit because quitting tobacco can have beneficial effects at any age. It's always better late than never when it comes to stopping tobacco use. The reason 12 was chosen as the starting rate has to do with input from our panels. The recommendations from the U.S. Preventative Services Task Force, which are the major guideline organization we rely on at NCQA. It's important for clinicians to ask the adolescent and pediatric population about their tobacco use, as many people begin smoking or tobacco use in adolescence and in early adulthood. So that's a really key time.
And you say there's no upper age limit?
There's no maximum age. That is to ensure that this measure aligns with current guidelines and also to recognize people might be ready to quit tobacco use at older ages. We want to encourage providers to ask about that.
So the proverbial 98-year-old grandmother who says, I've smoked all my life and here I am, I'm fine. We're still expecting health plans to assess or counsel that 98-year-old smoker, correct?
There might be a 97-year-old or a 99-year-old next to them that has been waiting to quit for an equally long time and might benefit from evidence-based treatment options that are available now.
This discussion about tobacco users who are young, tobacco users who are old makes me wonder, what's different now about tobacco use compared to earlier decades?
In spite of the many Surgeon General warnings, there's been conflicting exposure to advertising that different generations have had, and there's a variety of newer tobacco use products out there. We're still trying to understand how COVID lockdowns changed tobacco use, but there is evidence that for some populations, smoking increased during the pandemic.
Really?
Yeah, which is surprising or totally understandable depending on where you live. For some people, tobacco use might have increased during the pandemic, or for some people, that was a time that they were planning to quit and they either were able to do that successfully or are still working on that. But with the variety of tobacco products coming on the market and younger people still starting to smoke, as well as older people who have issues stopping it, it really is a very relevant issue for all sorts of disciplines and patient subgroups.
This sounds like another important aspect of this measure, the range of nicotine delivery system that it includes or that it covers. Are we talking about vaping?
Vaping and so much else. Most people would recognize cigarettes, pipes, cigars, maybe chewing tobacco. A lot of people have seen e-cigarettes and vaping devices out and about. But there's also hookahs and water pipes. There's cigarillos, small cigars. There's snuff. There's dissolvable gels, orbs. There's a lot of products to list. This measure was developed with all of that in mind. We hope to institute a measure that recognizes the complexity of that and that providers in different cultural contexts, different regions are able to use the same way. One question people ask is whether vapes are included as a cessation intervention in this measure. That's kind of a hot button issue. The answer is vapes are included in the measure as tobacco use, but they're not included as a cessation intervention. So somebody vaping that would meet the criteria for tobacco use, but electronic nicotine delivery systems, ENDs, or vapes are not included as a cessation intervention because our measure is limited to FDA-approved medications, and that does not include vapes.
So we've established that the who of this measure is new. That is, it applies to everyone age 12 and up. The what is new in that the measure applies to a wide range of products, including e-cigarettes, at least for the part of the measure that checks whether the doctor asked the patient about tobacco use. Let's turn now to maybe the most significant difference, how this measure gets reported. Grace Glennon, you've been waiting patiently, and your background is in digital informatics, and that tells me you are the perfect person to explain this. The abbreviation for this new measure, tobacco use screening and cessation intervention, the abbreviation is TSC-E. What does the E stand for or mean?
Yes, the E at the end of our measure abbreviations refers to measures that use the ECDS reporting methodology. That stands for Electronic Clinical Data Systems. That is a method that provides a structured way to start using more electronic data in HEDIS reporting.
And why does it matter that this new tobacco measure is using the ECDS reporting method?
The ECDS reporting method promotes the use of electronic data and standards, and it requires all data to be stored in structured standard layouts. That then helps for data sharing.
Data can move more easily from providers to health plans to patients to whoever needs that data. That's important for a lot of different measure concepts, but particularly for the tobacco use and cessation measure, it can be powerful because tobacco has been a public health issue for a long time now.
So if we can start getting the data in structured fields, start getting the data mapped to standard terminology, that helps it get to more people and used in better ways to actually make sure we're tracking health outcomes appropriately, understanding what's working and not working. And so it helps from a quality measure, accountability perspective, but also can be used to improve quality of care and health outcomes.
It sounds like this is a new approach to an old problem.
That's a great way to look at it. There's so much happening in data standards and interoperability. We're taking advantage of all of the work happening in the ecosystem related to interoperability standards and using that in HEDIS to push the whole industry forward. So it is a new approach to an old problem.
So electronic clinical data systems, does that mean digital measures?
No, ECDS and digital measures are different. ECDS is a reporting method that encourages the use of more data, things like administrative claims that are used kind of in our traditional HEDIS measures as well, plus things like clinical registry data, health information exchange systems, and electronic health records or EHRs. That's really to encourage the use of electronic data in a structured way and start getting that data to move more consistently. It sets us up for more successful digital quality measures or DQMs, which are actually a format in the way that the measure is structured. So our DQMs use a standard terminology via CQL to express our measures in both a human readable and computable way that the data can be churned and spit out results in a more standardized and quick way.
How should people think about the relationship between ECDS reporting and digital measures or DQMs?
I see ECDS as a stepping stone to the data we need to be able to move towards DQMs. It is a way to start leveraging electronic data, moving away from administrative claims data and getting closer to care provided.
And so the goal with ECDS is to prepare that ecosystem to move towards digital measures and leverage the electronic data in structured formats and set up that pathway for exchanging data. One thing that's important about digital quality measures is that with DQMs, you can provide a lot more granular detail in results than can be typically provided when you're just doing accountability for reporting purposes. So in the tobacco use screening and cessation measure, cessation can come in a lot of forms. It can be counseling, it might be medication. And while for HEDIS reporting, we may only require you to report if any of those activities occurred. For other uses like public health or quality improvement, you might want to see more granular information about cessation activities. So we can do that with the digital measures without adding burden on the reporter or the user.
You referenced both quality reporting and the exchange of data itself. And it sounds like you are focusing on two things or operating on two levels at once. Can you tell me more about that?
Obviously, our hope with all our HEDIS measures is we are improving the quality of care provided. So the first thing we look at is the performance on the measure. Are people performing well? Are they screening the majority of their population? And are they providing cessation intervention when it's appropriate? But secondarily, as we move to more ECDS reporting, as the whole ecosystem is trying to get access to better electronic data, there's also this importance of feasibility, and is the data that's necessary for this measure being able to be accessed by health plans is also important, because if the data can move, we know more what's happening, and then we can ultimately circle back to improving care. So I like to look at it from both perspectives.
And Jules, what surprised you most in developing this measure?
One thing I found surprising was the usefulness of pharmacotherapy for tobacco use cessation, pharmacotherapy for tobacco cessation interventions, nicotine replacement therapy, and the other FDA-approved medications really do make a huge difference in making quit attempts more successful and shorter. People have heard of the nicotine patches or perhaps seen them, but it surprised me just how effective those treatments are, considering how underutilized they are.
Grace, same question for you. In preparing this measure to be ECDS reportable, what has surprised you?
A pleasant surprise, I would say, is the concepts we were looking to define in this measure, be it screening or cessation, had standardized terminology, standard codes we could use to say this is the concept we're trying to represent. One thing that was surprising and maybe is a misconception is even brief counseling as short as 15 minutes is impactful in helping with cessation. Often people think you have to do this lengthy counseling session to have any impact. The evidence shows otherwise.
Final question. What would you like our listeners to do based on what you've shared here today?
I'd love the audience to read up on ECDS and digital and understand NCQA's direction if they're less familiar with it, so anyone in the healthcare industry can support the movement towards standardized structured data and using interoperability standards.
I would love for provider-facing members to educate themselves on tobacco use in their communities and the latest evidence-based cessation intervention treatment. It's important for patients and members across a lot of different domains.
I think that's a good place to leave it. Jules Reich and Grace Glennon of NCQA, thank you for being part of Quality Matters. We appreciate you walking us through all these important topics.
Thank you, Andy. Really appreciate your time.
Thank you, Andy.
Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts. We'll see you next time.